Hello and welcome to another episode in our mini-series on geriatric care, hosted by the GenerEHlist, where we discuss all things geriatrics. If you are interested in hosting an episode, please connect with us. We'd love to have you join the conversation about older adults. My name is Dr. Natanya Russek, and I am a PGY4 Geriatric Medicine Fellow at the University of British Columbia.
I'm Dr. Mehar Kang, and I'm an incoming Geriatric Psychiatry Fellow at UBC.
Today we're going to be discussing delirium. Our objectives are the following. Number 1, recognize delirium and apply the CAM scoring tool to make a diagnosis. Number 2, outline the usual workup and physical exam for the delirious patient. And number 3, identify pharmacologic and non-pharmacologic management appropriate for older adults experiencing delirium.
Let's start with the case. Let's meet Gurmeet, a 75-year-old female who lives at home alone, who comes to the ED with 2 days of new onset confusion. The ED calls you to ask for admission to the hospitalist service at your local hospital. On a chart review, she has a diagnosis of hypertension, diabetes, osteoarthritis, and a TIA 10 years ago. Her medications include Ramipril 5 mg, metformin 1 gram BID, Tylenol 500 mg BID, rosuvastatin 10 mg, and ASA 81 mg. There is no known history of cognitive impairment. You see the patient in the ED, and she is accompanied by her daughter Priya. You ask the patient about a general review of systems, and she says no to everything, including any localizing infectious symptoms. At this point, you turn to her daughter Priya, who says she talks to her mother on the phone every day, but last saw her on the weekend. She went by last night to check on her because she did not answer the phone and found her sitting on the toilet, unable to get up and confused. She did not witness any seizure-like activity, injury, urinary incontinence, or tongue biting. Her speech was not slurred, and she has no unilateral symptoms. Priya called 911 and the patient was brought in. Priya says when she last spoke to her mother, she had no specific concerns. She had no sick contacts, travel, or change in her medications. She takes no supplements or herbal products. The patient lives independently and gets no help with ADLs or IADLs. With all of this in mind, how do we define delirium?
Delirium is an acute state of confusion that is often fluctuating and, most importantly, different from a patient's baseline. The cardinal feature of delirium is inattention, and at least one cognitive domain must also be impacted, such as memory, disorientation, language, or perception. Often individuals with vulnerable brains or neurocognitive disorders are at higher risk of delirium, and it's important to obtain collateral history from reliable sources regarding baseline mental status and functioning to determine whether the presentation is an acute change from previous. Delirium is a major risk factor for mortality, discharge to care facilities, and future cognitive impairment, especially if untreated.
So, we hear our patient is clearly confused, but how do we know if she is delirious?
Delirium is a clinical diagnosis. You can use your mental status exam to identify delirium even without any special testing. Agitation, restlessness, climbing out of bed, paranoia, and tangential speech can be clues for hyperactive delirium, while somnolence, psychomotor slowing, or decreased level of consciousness are clues for hypoactive delirium. Visual hallucinations can often be present. There are different clinical tools you can use to make the diagnosis. One tool I often use is the Confusion Assessment Method, or the CAM score. The CAM score has a positive likelihood ratio of 9.6 and a negative likelihood ratio of 0.16 for the diagnosis of delirium, so it's a tool I often use in clinical practice. To be, quote, CAM positive, the patient must have an acute change in their mental status from their baseline and must have inattention. They must also have either disorganized thinking or an alteration in their level of consciousness.
Inattention can be tested in a number of ways. There is evidence from a small study for using days of the week backwards, but other options include months of the year backwards and spelling world backwards. Sometimes the months and the years task isn't as feasible in certain languages. In that case, I use digit span forwards and backwards. When I'm assessing a patient, usually I use months of the year backwards, but any of these options can work well.
And here, it's really important to note that disorientation, for example, not knowing the month or where we are, is not a necessary criteria for the diagnosis of delirium. Inattention is the only cognitive domain required to make the diagnosis.
Let's turn back to our patient and apply what we've discussed. Gurmeet is withdrawn. She doesn't spontaneously initiate conversation, and you have to ask her questions multiple times to get her to answer. On days of the week backwards, she says Saturday multiple times and then trails off. If we walk through the CAM score, we know from her daughter that this is an acute change from her baseline, and she now has proven she is inattentive. With more questioning, she accurately tells you her name and her daughter's name, but says the year is 1983. She is unable to state the month, date, day, time of day, city, or place. She is a limited historian and is unable to clearly describe her health history or circumstances of admission. At this point, she keeps falling asleep and you have to keep tapping her to get her to wake up. Now we know she's CAM positive, as she has an altered level of consciousness.
So she probably has hypoactive delirium, right?
That's right. We often think of delirium as a hyperactive state where patients might become restless or agitated, but about half of cases of delirium are hypoactive, where patients have decreased responsiveness, psychomotor slowing, and reduced awareness. It's really important to identify cases of hypoactive delirium, as these patients have worse clinical outcomes. Many patients fluctuate between hyper and hypoactive delirium during one hospitalization, and this is characterized as delirium with mixed features. So now that we have made a diagnosis of delirium, what other physical exam or workup should we do?
The workup for delirium is focused on identifying the cause. In a patient like Gurmeet, where we have little to go on from her history, we must be thorough in our physical exam and investigations. We can break this down using the DIMS-R mnemonic.
Let's start with D for drugs. This includes side effects from medications with anticholinergic burden, abrupt discontinuation of drugs, and substance withdrawal or intoxication. Getting a substance use history from the patient or family when possible, and a serum or urine tox can also be helpful to screen if no collateral. Importantly, the time of last drink of alcohol is relevant to rule out delirium tremens.
Next is I for infection. A good physical exam can be helpful in a patient when symptoms aren't localizing. Do they have any signs of sepsis or shock, or any localizing features like abdominal pain, respiratory abnormalities, cellulitis, or meningeal signs? I suggest taking off their socks to make sure that you're not missing a cellulitis or a diabetic foot wound, and asking another staff member to help you position the patient so that you can examine for any sacral wounds. Most patients with delirium should have a workup including a CBC with differential, urinalysis with reflex culture, and 2 sets of peripheral blood cultures. In Vancouver, in the fall, winter, and even now, it's often flu and virus season, so we usually swab for COVID, sometimes RSV and the flu, because it's often going around. Even if patients don't complain of respiratory symptoms, I will often do these viral swabs, as older adults can present with only delirium as their only symptom. Other tests like imaging can be dictated depending on what you think is going on. Consider HIV or syphilis serology if there's a concern of a rapid decline in cognition. If there's any features of seizures, meningismus, or other neurological signs, we may consider a lumbar puncture to look for an infectious cause like encephalitis or meningitis.
M is for metabolic. This is a broad category that includes hypo and hypernatremia, hypercalcemia, acid-base disturbances, renal or liver failure, hypo or hyperthermia, hypo or hyperglycemia, and hypo or hyperthyroid states. A basic workup will include vitals, renal and liver function, CBG, TSH, and extended electrolytes. Nutritional deficiencies may also occur, like thiamine or niacin, where one looks for dermatitis, diarrhea, and poor cognition. We usually make sure a B12 has been checked in the last few months, as a low B12 can contribute to chronic confusion, gait abnormalities, and sensory changes, but alone may not be responsible for delirium.
S is for structural. Classically, we think about CNS structural problems like a stroke or a mass, and sequelae like a seizure. It's important to note that a stroke that causes decreased level of consciousness is usually quite an extensive area of infarct or hemorrhage, or has brainstem involvement. A screening neuroexam is appropriate for all delirious patients. I usually include structural heart disease also on my differential and throw in a troponin and an ECG into the workup. Myocardial ischemia often presents with delirium and can be missed. Do you get a CT head on all of your patients who are delirious?
I think I get one about half of the time. To be honest, a lot of the time the CT head has already been done by the ED doc before we see them. Certainly, if I have any suspicion for focal neurological deficits, if they have fallen with any possible head trauma, if they're on anticoagulation, if there's a history of malignancy, or if they had a seizure, I always get a scan. If there is nothing that points to a neurological cause and I have a good alternate explanation, I often do not. But if they don't get better with targeted treatment in a few days, then I will order the scan. There's a 2022 JAGS meta-analysis in which the overall yield of a CT head in the inpatient or ED population was 13%, but higher, about 18%, if there's focal neurologic deficits. If delirium is worsening or not improving, it may be worthwhile to obtain repeat neuroimaging or an MRI brain or consult other colleagues.
Lastly, R is for retention. As a future geriatrician, I am always thinking about constipation and urinary retention. For all of my patients, I get an abdominal X-ray to assess for fecal loading and a post-void residual, or PVR, to assess for urinary retention. Bowel charting is also helpful to monitor this in admitted patients.
So let's go back to our patient.
So we do a screening physical and neuro exam, and we find that the patient has some abdominal pain on palpation, but no peritoneal signs. You send the usual screening workup that we've outlined, as well as some dedicated abdominal imaging, and find acute cholecystitis. You start her on antibiotics and call general surgery for a consultation. Besides treating the underlying cause, are there any treatments that we know will be beneficial for patients who are delirious?
There is a large body of research studying multi-component non-pharmacologic interventions. This includes things like reorientation, ensuring regular bowel movements, removing lines or restraints, including soft restraints, prompting regular sleep, ensuring euvolemia, and having caregivers visit. A Cochrane review found that this strategy probably reduces the incidence of delirium compared to usual care by around 40 to 45%, and also may result in a small reduction of around a day in the duration of a delirium episode. These strategies can be challenging to implement in a busy hospital environment, but they are the best evidence we have. I usually counsel caregivers to visit when possible and provide gentle reorientation to their loved ones when they're confused, even bringing in familiar photos or items. Clinically, it's also helpful to ensure adequate pain management through Tylenol rather than opioids if possible, having a window bed if possible, and addressing circadian rhythm or sleep-wake disturbance with sleep charting or melatonin at 8 p.m.
So let's say the patient is acutely agitated, or you're worried they could become agitated while waiting for surgery. Would you prescribe any antipsychotics?
The most important point is that the decision to use antipsychotics in delirium should be an individualized one and one based on safety. Antipsychotics can be considered for patients with delirium experiencing severe physical aggression, but it's important to note that antipsychotics have not been shown to decrease the rate of or shorten the duration of delirium, and most importantly, are actually associated with a lot of harm. They have a black box warning for risk of death and stroke for use in patients with dementia. Therefore, it's important to ensure the patient's family is aware of this risk if antipsychotics are clinically indicated, which can be a sensitive conversation when evaluating risks, benefits, safety, and importantly, education about delirium itself and its management. For patients that are agitated, I use a low dose of a PRN available with parameters to hold if the patient is drowsy. For example, I might use haloperidol 0.25 to 0.5 milligrams, PO or IM, Q4 hours, or quetiapine 6.25 to 12.5 milligrams, PO, Q6 hours, which is a safe option for patients with Parkinsonism as a low-potency agent. If an IM or sub-Q option is needed, loxapine 2.5 to 5 milligrams is a practical option, and it is a medium potency neuroleptic. Notably, close monitoring for any EPS, falls, oversedation, and QTC prolongation is advised when using these agents. What if you also got a history from the patient's daughter that the patient has a drinking history? How would this change your management?
This is one of the only exceptions to the sort of no benzodiazepines for older adults rule. Benzos have a few indications. Alcohol and benzodiazepine withdrawal and seizures are the most common reasons. The CWA protocol is actually pretty nonspecific, and patients who are sick and delirious for many reasons can often score positive on the CWA scale, not because of alcohol withdrawal. Therefore, we suggest that you do your own risk assessment with the patient and by getting good collateral. For this patient, if we had no idea how much she was drinking, it could be worthwhile to monitor with CWA protocol and see if PRN benzodiazepines are effective at treating her symptoms or actually just making things worse. So, what happens to the patient?
Well, we will actually revisit this case again in our next episode on consent and capacity.
So before we wrap up, when would you suggest a geriatric psychiatry consult for a patient like this?
Many of you may be training or practice at a center where you have access to geri medicine or geri psychiatry. Geriatric psychiatrists have expertise in the assessment and management of delirium, especially if you have patients with comorbid psychiatric history or who are very agitated and not responding to the usual low-dose PRN antipsychotics. A geri psych consult can be helpful. Also, if concerns around diagnostic clarification, capacity, management of behavioral psychological symptoms of dementia, a referral can be helpful. Other team members usually include allied health professionals like social work and occupational therapy. How about a geriatric medicine consult?
In geriatric medicine, we develop a lot of skill around the workup and management of delirium. So especially if you can't figure out what's driving your patient's delirium, I'd suggest a geriatrics consult if it's available where you're working. Just like geriatric psychiatry, we can also help with diagnostic clarification. I often get asked to determine if a patient's confusion is new from delirium or actually chronic from something like dementia. Geriatricians also often see patients in the clinic a few months after discharge. Delirium is a risk factor for permanent cognitive dysfunction and functional decline, so feel free to refer your patients after a hospital stay with delirium to be seen in the geriatrics clinic. If you don't have access to geriatric medicine in your community, a cognitive assessment in the clinic around 3 months after discharge is helpful to identify if there is underlying or maybe newly revealed cognitive impairment.
Thank you. I guess that's a wrap. Let's revisit our learning objectives. Number 1, recognize delirium and apply the CAM scoring tool to make a diagnosis. 2, outline the usual workup and physical exam for the delirious patient. 3, identify pharmacologic and non-pharmacologic management appropriate for older adults experiencing delirium.
Great. So if this episode was helpful, we encourage you to pass it on to your colleagues. Thanks so much to our reviewers, Dr. Robynn Lester from Geriatric Medicine and Dr. Cindy Liu from Geriatric Psychiatry. Of note, the opinions expressed are our own and do not represent any affiliated organizations or institutions.